Okay.
So this was a recent case. A woman in her 60s who presented to us for follow-up of an abnormal finding on a recent PET examination. She had had approximately 14 prior PET CT examination for follow-up of breast cancer, and recently they'd all been negative. On the nuclear medicine portion of this examination, they did not note any significant radiotracer uptake, but on the CT exam, they noted some hypodensity in the left hepatic lobe, and they queried a possible lesion that needed further evaluation. This actually came to us for MRI, and given the history of breast cancer, an EOVIST MRI was performed, and the 20-minute hepatobiliary phase image showed a region that was that had no contrast uptake. But when we reviewed the case more closely, we noted on the T2 images, this so-called lesion kind of had this appearance.
I don't know if it's just me, but your T2s are really dark. I can't see the liver well. Yes, that's better.
So
Sorry, did you have the portal venous phase?
I do have the portal venous phase. I'll pull that up.
Here it looks like flavoids and like a tangle of vessels.
That's actually the conclusion that we came to. But on the portal venous phase, it looks like this. I can go back.
Yeah, there it is.
This is the 60-second, and I think this is very helpful. If you go back to the first arterial phase, that region is not conspicuous, and similarly on the pre-contrast, obviously there is but as Aarti mentioned, the 60-second kind of shows it to have very similar signal to the vessels around it, and we feel that this may represent a vascular malformation. So good for this lady that she doesn't have metastasis in her left lobe.
It also looks like that left portal vein is large, which is like, it's like feeding this vascular malformation. It
That's
almost
what-
looks like an AVM or something with like, and then hypertrophy of the left portal vein.
That's something that we mentioned here. I agree. Yes. So this was an interesting case, and helpfulness of MRI in problem solving.
Cool, thank you. Nelly, you said you had some, right?
I'll go at the end. I wanted to share PacsBin, and then I can load up the case in the interim.
Okay. Anyone else? I can share some while we're, if anybody else has cases, type them into the chat. Okay. So this case is a 25-year-old male who has this lesion in the tail of the pancreas. This is the pre-contrast. You can see it standing out against the T1 bright pancreas. And then this is the post-contrast. You can see that it looks like it's enhancing. And then this is the T2. Any thoughts?
Be a cystic neuroendocrine.
Good. We also brought up like maybe a torsed splenule because it was like a little bright. But they got a spleen scan, it did not light up. Anything else? Okay, so this is just a follow-up to last week. Remember we were talking about SPEN lesions and like whether or not, they're typically, there was like question raised like, oh, is it typically in a female, an African-American, etc. So about 90% are in females. I think last week I said 85%, but 90% are in females. So it is female predominant, but males can get it. And this was a male with a SPEN tumor. And then the other thing that I found interesting is that this is really solid appearing. And we think about SPENs like the stereotypical like description is they're large tumors and they're cystic and solid. But that's kind of being like a kind of larger understanding of it is that when they're early on, they're actually solid tumors. And then as they grow larger and larger and outgrow their delicate vascular blood supply, that's when they become hemorrhagic and cystic and solid. So if you see like a solid appearing tumor, but that has like smudgy enhancement, I think the big two differential would be a neuroendocrine tumor and also a SPEN tumor. And they can be found in males, about 10% are in males. They can be in the body or the tail, and they don't have to be large. They can be smaller, and when they're smaller, they're solid. And there's actually been a 7-fold increase in detection of SPEN tumors in the past 15 years. And they think that's because before when they would present when they would grow large and become symptomatic, but now we're finding more incidentally. So this might not have been symptomatic, but they found it incidentally for diffuse pain, and then we're diagnosing these SPEN tumors. So take home point is that you can see them in males or females, but more in females, 90%. They can be solid when small, cystic and solid when large because they hemorrhage, and they're increasing in frequency because of their incidental pickup. And so it's not necessarily going to be a very large lesion. And they are low-grade neoplasms, so they have a 95% 5-year survival. So some of them can metastasize, but overall they do very well. I'm just going to show a couple of companions. This was also a young male, a 22-year-old male with this lesion in the pancreas. You can see it's pretty solid looking, but a little T2 bright. And on the post-contrast, it pretty homogeneously enhances, so it looks like a solid mass. This was also a SPEN tumor or solid pseudopapillary neoplasm. This is another case. This was in a young female. It was a kind of also, again, heterogeneous, smudgy looking, but mostly solid appearing mass. At this point, this is a really nice example of how, as it's getting larger, it might have this T1 hyperintensity in it, which is a strong clue for SPEN tumors because of that hemorrhage. And then on the post-contrast, the non-hemorrhagic parts kind of enhance. I don't know why it doesn't look like it's that enhancing, but this part is still going to be solid. And on path, it's going to be that sort of pseudopapillary architecture. So yeah, this is the hemorrhage in the center, and then this kind of smudgy pseudopapillary part that's enhancing on the outside. And I think I have one more. Here's another one in a female. So you can see it can be in the tail, it can be in the body, head. Again, this is another one that has like a solid part and a cystic part. When we do our MRI pre-contrast, the cystic-y looking part actually has some T1 hyperintensity. And then when we go to the post contrast, it's almost like a yin yang. So for example, this is the hemorrhagic part that's like non-enhancing, and then this is the pseudopapillary part that on the post-contrast is enhancing. So that's why it's called like solid and cystic, but it's actually basically solid and hemorrhagic. So any questions about SPEN? Okay, this is my next case. This was an MRI for a patient with abdominal pain. Is someone in my group shared this at our conference. So if you look in the pelvis, there's this interesting thing here. This is a female, and we don't see a uterus. initially you could think this could be the uterus, but they'd had a hysterectomy. So what do you guys think about this? I can show you some post contrast. So here it is.
Do you have the chronos?
Yeah. But you can see there's like a bowel loop going into it and then coming out of it.
Yeah.
Probably like Crohn's disease, segmental thickening.
Or like lymphoma. I mean, just soft tissue-y.
Yeah, exactly. So those are the two things that we should think about. It's really thick though, right? It's quite thick for Crohn's, and here it is. It's almost like mimicking a uterus. But anyway, so this was long segment thickening with homogeneous enhancement of the wall. And let me just see if we have a
No transplant, right?
No. What were you thinking about?
No, I was just like a lymphoma weirdo stuff.
Yeah, like PTLD or something.
Yeah.
Anyway, they did a small bowel push enteroscopy and took a biopsy of this, and this was diffuse B-cell lymphoma. So it was, and this is the only place that is involved. So I showed a case a couple of months ago of just small bowel lymphoma. So you can get primary small bowel lymphoma. It does not necessarily need to involve other organs. It can be treated actually by resection. And those patients usually do quite well. And yeah, this kind of thickening without obstructing the lumen is more typical for lymphoma than like a malignancy, but definitely like severe Crohn's disease could be in the differential. The rest of the bowel looked normal. Okay, this is my next one. Melina, this was the case we discussed. This is Melina's case. So this patient, you can see that this is their CBD here. And their CBD is actually connected to the duodenum. This patient had a history of a cholecystectomy that was complicated about 20 years ago. And they said they did some kind of anastomosis. So what we learned was that before ERCP, if there was any stricture in the distal common bile duct, they used to do something called a Choledochoduodenostomy, where they would anastomose the anterior part of the bile duct to the duodenum. I'll show you on the axials too. So if you ever see this, this is a known surgery they used to do where the bile duct is just anteriorly anastomosed to the duodenum. And in this case, contrast that was in the duodenum was kind of going into the bile duct and then going both up and then down through the common bile duct. But it's a way to, if there's a distal common bile duct stricture, to drain the bile into the duodenum there. And then we learned that there is a syndrome associated with this. It's rare, but does anyone know any problems that come up with this kind of surgery? I'd never heard of it, so I thought I would tell you guys about it. There's something called Sump Syndrome, where basically the distal CBD acts as a sump or a reservoir. And so say like they still had the stricture down here, that's why they did the surgery. And then debris and stones collect in the distal CBD. It can actually cause repeated bouts of cholangitis because of the sump. So just something to be aware of. If the patient does have an anastomosis between their mid CBD and the duodenum, the distal CBD can act as a reservoir for debris and cause Sump syndrome. Everyone's very quiet today.
Learning attentively.
Okay. And then this patient, I just have two in a row of this, which I thought was interesting. This patient had COVID. They had barotrauma. They ended up with extensive pneumomediastinum. And then this dissected into their abdomen. And so my resident was asking me like, you know, is this free air? Is this intraperitoneal air? And basically what you can see is that it's not really free air. It's not just like going elsewhere in the peritoneal cavity. It's basically anterior to the peritoneum. And so this is in what we call the preperitoneal space. It's basically the space between the peritoneal lining and the transversalis fascia. And I have a, let's see if I can pull it up. Oops. Okay. So basically, this orange line here is the peritoneal lining, and then there's like a little bit of fat, and then this posterior rectus sheath, or the transversalis fascia lower down, is another fascial layer. So you can actually get dissection of air between the peritoneal lining and this transversalis fascia. So I just thought it was kind of interesting reminder of the different fascial layers of the abdomen. And I actually have a second case where the same thing happened. In this case, this patient also had barotrauma, lots of pneumomediastinum. And then you can see that it's actually in like basically in the rectus sheath, and then kind of posterior to the rectus sheath, but not into the peritoneal cavity. So here we can see like that's basically the rectus sheath / transversalis fascia. This is the peritoneal lining. There's air here, and there's also air between the rectus muscle and the rectus sheath. So it's not that clinically relevant, but I guess you wouldn't call it free peritoneal air. And they can also dissect, it can dissect also into the retroperitoneum. So you can see there's a little bit here. So these fascial planes see right here in the anterior perianal space. So these, the air can really travel along some of these fascial planes. Okay, that's it for me.
These are great learning points. Thank you.
No problem. Okay, Nelly,
I'm going to share my screen. Yeah. Where is? Can you see my screen?
Yep.
Yeah.
Okay, cool. This is a patient came into the ER, UTI.
Gonadal vein thrombosis.
Gonadal vein thrombosis. Okay, yeah, that's a good thought. So let me see, where is a gonadal vein? It would be somewhere coming along the IVC, coming off. But this one goes all the way down into the pelvis.
It's like septic thrombophlebitis that is from the internal iliac has traveled up.
That's a great thought. When I saw this, the patient had right lower quadrant pain, and this looked a little weird. So
Nelly, it's jumping around for me. Is it jumping around for you guys?
Oh, sorry. Am I going too fast? Maybe it's my.
It might be my internet speed, but.
Okay, I'll go slower.
See, I think she's saying gonadal vein thrombus because it looks like a dark thing surrounded by a rind, right? But is that not the gonadal vein, or is that the ureter surrounded by a rind?
Yeah, that's a great thought. So let me give you, I don't know if the kernel is going to help you. And I'm like, this is not the appendix because it goes into the pelvis and it's not really continuous with the cecum. So I recommended.
What's going on with the right-sided collecting system? Like where's the ureter?
Right. Yes, that's a great question. This is just the ER scan. So it's just a routine portal venous phase. So there's the right ureter. And this thing is anterior to the right ureter. But it goes along with the ureter. And then I don't know where it goes here. So I recommended a CT urogram. And oh my goodness, this is so cute. There's contrast, opacification of the ureter. Let me do that. This is going to skip, but because I'm going fast, but here it is. See, it fills. So I think it refluxes back from the normal looking ureter and then goes into this. So this is a bifid ureter.
Is it bilateral?
No, I thought it was just unilateral, but let's double check. Where's
There's
my
2 ureters there on
Radiopedia?
the left side.
Where's my, oh man, I had a Radiopedia thing up. It was, shoot.
I think Teresa's right. It looks like there's 2 ureters on the left as well.
2 ureters on the left. Oh yeah. But this one is a blind ending bifid ureter. So there's a weirdo, can you see my Radiopedia?
Yeah.
So I think it's this. So you have right, it's like a bifid ureter, and one of the ureters blind ending. And it's inflamed, which explains, this patient has recurrent UTI. So that's what I thought it was. What do you guys think? And then the left side, yes.
That looks exactly like yours. It's very
Yeah.
true.
And there's a duplicated collecting system on the left. Okay. All right. So then that's one case. The other case, I don't
Nelly, is there a
have,
name for that?
I don't know what the name is. I just describe it.
Yeah, I think that's better anyway. I don't want another name, but
Yeah.
reflux into a blind ending bifid ureter.
Yeah.
Yeah, nice case.
The second case, I just pulled it up, so I don't have like nice educational thing, but I think it's good because then I can learn from the rest of you. This is a patient with CLL, and the patient is on Ibrutinib, Ibrutinib. And I learned this from Cookie. Patients who are treated with Ibrutinib for CLL, they can get these fatty like spots in the lymph nodes after treatment, and that's like a normal response, and it's a good prognosticator to therapy, apparently.
Is it the fatty hilum coming back, or like is it and were those nodes like smaller now, or you're saying like it's a fatty dot in it? It doesn't make it look like back to having a hilum.
I thought it was. I think it's more. I don't know if it's the hilum that's hypertrophied or additional fatty dots in addition to the hilum, but you get these. I don't know. Like from my understanding, it's just these blobs of fat within the treated lymph nodes after this kind of therapy. Teresa or Ben, do you guys have you? I know she's presented cases of these fatty deposits in the lymph nodes after treatment. Was it? Sorry, I didn't dig deep into this into Google to give you something intelligent something more intelligent. Teresa or Ben, do you guys have anything to add to this?
I've seen this before, but I'm not 100% sure why it happens like that. I'm gonna look at it and say something once I find something useful.
Yeah, I'll take a rain check on that too, Aarti, because your question is a good question and I don't know what the answer is.
Yeah, it is cool though. They don't look like normal lymph nodes there. They
no, yeah.
Dots.
And it's a treatment associated. It's these blobs of macroscopic fat, or it's treatment associated with this Ibrutinib for CLL. Okay, cool. Oh, and I can do the PacsBin. I can share with you guys PacsBin stuff if no one else has cases.
Yeah, that would be great. Did you just use PacsBin?
I'm starting to, yeah.
But for those 2 cases, you used it?
No, I use Visage.
Okay, got it.
Yeah. So what?
Go for it, show us.
Okay. So I started looking into, Cookie and Perry did the unknown case panel at SCR, and they used this thing called PacsBin. Did you guys see this? Did you guys watch the unknown? It was awesome. And I guess it's a way to anonymize cases. So I wanted to try to create an MR curriculum for our residents when they come on abdominal radiology. And part of it is, you know, kind of like showing cases, right? And we don't have like a good way right now to have a repository for great cases. So then I started looking into an alternative. And so I found this PacsBin. I saw it again during during AUR again, and others are using it. So anyways, it's nice. Like you download the DICOM. We use Visage. So we have this way to anonymize the DICOM when we download it. And then you just upload the entire file into PacsBin, and then it separates out the sequences for you. And then it goes through a second set of anonymization called RIT. I guess it's like RSNA software to anonymize the DICOM images. And then when you do this, you have this anonymized images, and you could scroll it and window it just like a regular viewer. And there's a link, so you can do an anonymized version or an answered version, and then give it to our residents and then review cases through this kind of like an anonymized viewer for teaching files. So we're checking it out and looking into maybe getting an enterprise account. So I'm excited about that. And part of me is sharing this with you guys because I have this dream of building a ginormous teaching file for abdomen and crowdsourcing all of you.
Mm-hmm. Thank you, Nelly. So I have a couple of questions for you. One, sometimes people talk about using like Horos or Osirix. This seems different because this is on the web. Is that true? Like basically you don't have to have some other application, and so
Correct.
it's easier. It's like one less step.
I think so. Yeah. Like I used Osirix, and that's all loaded on your account, like on your computer database, like a hard drive. And you can get an online account, but it's super expensive and it's not super user friendly. And everyone has to download the actual Osirix into your Mac, and it's only Mac compatible. It's not on it's not on Chrome. It's not on a browser.
Cool. And then you were telling me you get like 20 free cases a year, and then after that you pay for it. So it's kind of limited it's good if you only have, one lecture you're doing or something like that. But then if you are going to use it more extensively, this is fee for service. Like,
yeah, totally. This is totally free for service. And I have no financial conflict. Whoever created this thing, I'm so happy they did. There's the one that I subscribe to, as I mentioned, is which is the next level, 500 cases, and it's $100 a year. And there's a abdominal radiologist, Michael, I forget his last name. He's at Wisconsin. He has 500 abdominal cases. So you could just take his link and then use that as your own teaching file for your cases. So
does he have to share his link or something with you?
Yeah, so you can make your links private or public. And so he's got 500 abdominal cases that he's made public.
So if I
just
logged in and got the free 20 account, then would I have access to his 500 cases?
Yeah, you don't have to have an account to access his cases.
Ew, that's a game changer.
Yeah, right. So let's say we all had the 20 cases account, or maybe you don't, right? But the medical student can still look at the cases, review it, and you can do the teaching session with them or residents or fellows or whoever, or your own colleagues, right? If you want to share it. And like Cookie and Perry, they did it as the unknown case panel for SAR plenary session.
Yeah, I think that's an awesome idea. You're inspiring me too, because even if you just put 500, even if you have more than 500, if you at least put 500, then you can have access to them anywhere you go, right?
Yes.
So you can just pull them up and be like, hey, let's look at a few cases, and you'll have the whole DICOM set. So that's really cool. He also, that guy, Michael Hartung, also posts some to Radiopedia. So that's another idea for people if they want to become a contributor to Radiopedia. That's another way to have it also be more searchable and longer lasting. But I think, yeah, this is a really cool way to have your own personal teaching file available. So my only issue is what if PacsBin goes away and then my 500 cases goes away? Or what if their prices go up? I already every year I'm paying more and more money to Apple. So anyway, but I think it does seem like a lot of people are a fan. So you can check it out.
So just a quick point regarding Dr. Tan's last case. I found a radiographics article from Dr. Amy Hara, and she talks about Ibrutinib causing the prominent fatty hilum, and she posits that it may be secondary to treatment, which shrinks the tumor and causes fatty replacement.
Cool. So it
Thank
is like
you.
a hilum, but like an exaggerated one because it looks bigger than like a normal one.
Yeah, the example that she puts in her paper, it looks like the hilum is like 5 centimeters large, and it is, like you said, very exaggerated.
Cool. That's huge. Okay. Does anyone else have cases? We will end early. Everyone get back to their lists and we'll see you later. Bye.
Thanks all.
Thank you.
Thank you.
Thank you all.